Welcome, everybody. Thank you for joining us today. My name is Nadia Primc. I am an associate professor for medical ethics at the Heidelberg University. And today I want to talk about the digital transformation of healthcare and what it means for patients. So the focus of my lecture will be on why it is important to keep the patient in the loop and what challenges need to be addressed in order to do so. I will structure my lecture in two parts. So first, I will talk about what the terms digital transformation and digital disruption and what this means in healthcare. And then second, I will look at AI-based clinical decision and diagnostic support systems and four important challenges they create. Let me start with some basic definitions. Digitalization means the transition from analog to digital information processing. In healthcare, this is often called e-health. What makes digitalization such a big topic in healthcare nowadays is not that this is an entirely new phenomenon in healthcare. So digitalization is not new to healthcare and medicine. For example, computers and monitors have been used for many decades now in nursing and medicine. But what is new is the all-encompassing nature of the process of digitalization that we see today. So it affects basically all areas of care, and it includes very different things. On the slide, you see here an exemplary list of technologies and use cases that often fall under the term of e-health and digitalization of healthcare. So, for example, surgical robots, social robots, but also mobile health applications like apps and websites that are used to support the treatment of patients. But e-health also encompasses monitoring systems like ambient assisted living, but also telemedicine. And of course, it includes big data and AI, but also AI-based systems that are designed to facilitate, to support the documentation and the billing, the administration of the healthcare system. So this is a non-exhaustive list, but what it shows, I hope, is that digitalization affects almost every part of the healthcare systems. It touches all professions, all areas of care, and all stakeholders. And if we want this all-encompassing digitalization to work, to become a success story, we need what is called digital literacy. And not just digital literacy of the healthcare professionals, but also to a certain extent, digital literacy of the patients and their families, if at least they are supposed to actively and successfully participate in a digitalized healthcare system. What is also important to understand is that digital literacy does not just mean knowing how to use digital tools, but it also means being able to critically reflect those tools, their limits, and the use of those tools. So this is why digital literacy is now being integrated more and more into different curricula and medicine in general. For example, it is supposed to become a mandatory topic in the medicine curriculum in Germany with the new medical licensing regulation that will probably enter into force in a few years. Another important distinction I want to introduce is the distinction between digitalization and digital transformation. Digital transformation is a widely used buzzword in today's discussion and promotion of digitalization of healthcare. And it is important to know that not every form of digitalization is in itself also a digital transformation of healthcare. For example, when it became obvious during the pandemic that the use of fax machines in the reporting of infection rates is not the best and the most efficient way to process patient data, and the healthcare systems then switch more to the digital reporting of those infection rates. So this switch from fax machine to digital tools is to more digitalized tools can hardly be regarded as a digital transformation of healthcare or infection medicine. A quote that I find very useful to make that distinction between digitalization and digital transformation goes back to a paper from Gong and Ribieri, and you find that citation here on the slide. As they put it, while all transformation is change, not all change is transformation. In other words, simply adding a digital system to your hospital does not automatically transform healthcare. Digital transformation is not simply digitalization. It means something bigger. It means some sort of fundamental change that is comprehensive, far-reaching, and that kind of leads to better outcomes. And this is important to note, because we wouldn't call something a digital transformation if it changes healthcare to the worse. So this is important to note. The notion of digital transformation in itself carries the promise that something is made better with the help of digital tools. Okay, but if digital transformation as a concept holds the promise of better outcomes, this, of course, raises the question, better outcomes for whom? And in the case of healthcare, I would say that the answer should be clear. These should always be better outcomes, first of all, for patients and also for healthcare professionals. But of course, which is also important to understand, simple digitalization also leads to changes. It also entails changes. And this is so because digitalization is not just a technological, but always what we call a socio-technical process. What we mean by that is that new technologies, not just digital technologies, but nearly every technology changes and also affects social processes. And also the other way around, every technical innovation is influenced by the social context in which it is introduced by social processes. For example, smartphones have changed the way we communicate. It has changed some very important central social phenomena in our society. So that new technology also led to social changes. That's why technological change has always to be regarded also as a socio-technological process. So how do we then recognize a real digital transformation? How do we distinguish it from simple digitalization? Gong and Ribieri suggest that it must meet what they call the 3 Bs. It must be big, bold, and, as I already said, lead to better outcomes. The change must be significant in scale, it must be strong in intensity, and actually improve things. This is reflected in the broad consensus that we find nowadays that digitalization will lead to big changes in medicine and healthcare. And the open question is a bit, what form will these changes take? Will they really bring about better health outcome, or will they have a negative impact on the nature and quality of healthcare? So the public and academic debate finds itself somewhere between utopian visions and dystopian fears when it comes to the digitalization of healthcare, and especially the broader implementation of AI in healthcare. And I would like to first give you an impression of the more optimistic and utopian vision. And this, which is actually closely linked to the concept and promise of digital transformation. There are, of course, very different versions of these visions, and but mostly all relate to what is often called the 4P medicine, which the 4P refers to prediction, prevention, personalization, and participation. A very well-known and prominent representative of this view is Eric Topol, that I already briefly mentioned in my first lecture. I will not go into that more deeply. You see the cover of one of his influential books here on the slide. But I want to briefly explain, say a little bit more about the 4Ps. So what the 4Ps stand for in the context of digital transformation of healthcare. The first P, prediction, means that digital tools can help to automatically collect and analyze data to detect and predict diseases and health risks before they become serious. And this, of course, helps to improve health, or at least gives the opportunity to improve healthcare. Prevention means that holds the promise that the automatic collection and analysis of data that will become feasible with the digitalization and especially AI in healthcare can also help to intervene earlier. So to induce a shift in medicine from a curative to a more preventive approach, so that it is no longer just mostly about curing, but about preventing diseases. And personalization means that the collection and automatic analysis of individual health data can be used to tailor treatments to the specific needs of every individual patient, so that we no longer have one-size-fits-it-all approaches in medicines, but that the paradigm that we nowadays already have in limited, highly specialized areas of medicine, for example, personalized oncological treatments, can be made more broadly available in all areas of medicine and to all patients, so at a way larger scale. And the last P, participation, holds the promise that digitalization AI will involve patients more actively in their own care. For example, through self-monitoring and self-management of their health and their diseases. That is, patients will be enabled to collect themselves continuously data on their health and their recovery, and thereby also make them more involved in their own care, which, that is another hope attached to the participatory approach, could also improve their adherence to therapies. So to sum it up, the 4P medicine promise entails the vision that healthcare will improve in the long run through digitalization and AI by better networking between professionals, faster and higher quality data analysis, and greater involvement of patients. So that's where words like empowerment and democratization are often used. So they are often used in that context. Okay, so that was the more positive view, and now let's turn to the more critical view of the all-encompassing digitalization of healthcare that we witness nowadays. This negative view is often associated with another widely used term, namely the term of digital disruption, and the characterization of AI and digital tools as disruptive technologies. Within the public and academic debate, the two terms are not always properly defined. So they are used as buzzwords, that's what I meant by that. And they are not always carefully distinguished from one another. So, for example, they are also often used in a form of circular reference. For example, the disruptive nature of AI is then explained in form of its potential to bring about a digital transformation. And on the other side, digital transformation is explained and described as the result of the disruptive nature of AI and digital tools. And in the end, we have a circular reference and have not explained anything at all. But one can say that in general, the term of digital disruption is more often associated in the debate with this more negative or even dystopian view of digitalization and AI in healthcare. Although that negative essence of disruption is seldomly explained. And yeah, from a medical point of view, this makes intuitively sense because disruption never means something good in medicine. Okay, but what does the term actually mean? And for this, it is helpful to go back to the origin of the term. And the term was introduced in the 90s, as in the 1990s, by Clayton Christensen. You see him here on the slide on the right, an economist at Harvard Business School. So it is important to understand that this term comes from an economic background. And at that time, what Christensen did, he wanted to explain a phenomenon that has been observed recurrently and more often in that time, namely that big and successful companies that clearly dominate specific markets, so have big economic power, sometimes fail to adapt to new innovations, to new technologies, and then get pushed away from startups, new innovative firms that in no means have the same economic resources that big firms possess and are still able to outperform those big companies. And this is something that needed at the time explanation from an economic point of view. And that's where the theory of disruption and disruptive technology comes from. So it is in its origin a theory of failure and downfall of big players, big stakeholders. Christensen and his collaborators, scholars, and then in the years to follow, then also tried to develop strategies to help big companies to prevent such a disruption and to prevent being pushed out of the market and out of their dominant position. And one lesson that Christensen and colleagues drew from their research was that companies should on a very early stage, try to integrate potentially disruptive innovations into their own strategy, or even better, become themselves developers of such potentially disruptive technologies. Okay, my main point is that the concept of disruptive technologies has a specific disciplinary background and is shaped by specific epistemological and practical goals, namely the ones of economic theory. And this limits its transferability to the field of healthcare, at least if and as long we agree that healthcare is not a purely economic enterprise. And healthcare should not be treated as a purely economic enterprise. Still, there's something useful in the concept of disruptive technology for our discussion of digitalization of healthcare. It reminds us that technologies in healthcare do have a higher risk of being disruptive to healthcare if they are exclusively developed by professionals outside of healthcare, by tech companies, by data scientists, each with their own values and priorities. This is what is sometimes called a technology push. So the engineer that has a hammer, a specific technology, and is looking for nails to use his hammer, is looking for use cases to implement his new technologies. So what we can also learn from Christensen's theory is that disruption can be countered. A digital disruption of healthcare can be prevented by actively incorporating the values of healthcare into the design of technology. This is why approaches like ethics by design and participatory technology development try to do. And there are also other lectures in our METIS lecture series that explicitly address these participatory approaches. I highly recommend you to attend them or to watch them later on once they have been published on YouTube. Now, let me briefly summarize the first part of my lecture. Digital transformation and digital disruption are not neutral technical terms. They are evaluative and normative concepts. This means that they are value-laden. They carry value judgments in themselves about what is good or bad for healthcare. And digital transformation mainly means strengthening the core values of healthcare, whereas disruption means that those values can be put at risk too by technological developments. And this framing helps us think more clearly about what we want from digitalization and what we want to avoid and how we can do that. Now, let me turn to the second part of my lecture, AI-based systems for supporting diagnostics and clinical decisions, that I will briefly present and then discuss a few challenges they bring with them. First of all, what are those AI-based systems that are supposed to support diagnostics and clinical decision-making? The potential of these systems is impressive, and I will just briefly give you two examples. The first example made the headlines internationally in 2020. That was when these results were first made public. It was widely and internationally reported in newspapers and really on a large scale for the first time underlined the potential of these diagnostic assistance systems. So that was a study by McKinney and colleagues. And what they did, they used Google DeepMind for breast cancer detection. So normally around 80% of carcinomas are detected and 20% are missed. And the headline at the time was that Deep Google Mind helps to reduce false positives by up to 5.7%. And false negative by up to 9.4%. What that headline at the time didn't mention was that this was only the case in one study arm, the one in the US, which in general is single reader setting. So that was study was done, it had two arms. One arm was done in the UK and one in the US. And in the US, you normally have just one radiologist that analyzes the mammographies. And they were comparing the system to that single reader setting in the US arm of that study. And there it showed that impressive reduction of false positives and false negatives that made the headlines worldwide. But they didn't observe the same reduction in the UK arm, where, as in many other countries, usually two radiologists analyze the mammographies. So the reduction of false and negatives and false positives in that setting and arm of the study was not as significant as in the other study arm in the US, but it still had a benefit as it reduced the workload of the second radiologist by up to 88%, because it already flagged the errors. The second radiologist was supposed to check and save them a lot of time. What this example shows, first of all, is that one has to be cautious when reading such headlines. But second, it also shows that these systems show significant results, and they have become even better since that time in 2020. This is an example of an diagnosis support system. There are also clinical decision-making support systems, and an often cited example is IBM Watson for Oncology, which is the second example I want to briefly introduce. Watson for Oncology does not just support diagnosis, but it also makes a suggestion whether a patient should be referred for further cancer treatment or not. And there are several studies worldwide that have compared the treatment recommendation given by Watson against the treatment recommendations made by real interdisciplinary tumor boards. And the agreement between Watson and those tumor boards varied depending on the type and stage of cancers. And one of the highest agreements at the time, almost 89%, was found for breast cancer in stages 1 to 3. I could have named many other examples for such diagnosis and clinical decision support systems from dermatology, neuroradiology, transplant medicine, and many other fields. We also discussed similar systems in our first lecture, where I mentioned a mortality prediction model used in the ICU to make end-of-life decisions, so decisions about withdrawing life-sustaining treatment or not. Or what I also mentioned in the first lecture was the I Chose kidney system that is used to support patients to make a decision, an informed decision for or against kidney transplantation. Let me briefly summarize the opportunities of those systems, which are all relative to the already mentioned ideal of 4P medicine in one or the other way. So those AI-based systems can improve disease prediction through more precise diagnostics. They also can expand therapeutic options by processing more scientific evidence than any single doctor, any single human could do. And they can also help realize the ideal of evidence-based medicine, treatment that is truly data-driven, because they can take into account more data than any human could. And of course, they have the potential to personalize care for individual patients. And which I also briefly mentioned is they can also help to reduce the workload of doctors. However, alongside these opportunities, there are several challenges discussed when it comes to the implementation of these systems. And I want to focus on 4 of them: the black box problem, the automation bias, the responsibility gap, and some issues around privacy and data use. First, the black box problem. The black box problem refers to the fact that it is very difficult for humans to understand how an AI system arrives at its output, its recommendation. You can see what goes in, the input, and what comes out, the output, but the internal reasoning process is often hidden, it is opaque, it is complex, too complex for a human to understand it in real time. And you may remember the 3 scenarios that I presented in my first lecture, where the healthcare team was confronted with mortality prediction models that are not fully transparent. So the challenge with this system is that we cannot interrogate or evaluate reasoning in any human terms. And still, sometimes we have to base very severe and consequential decisions on the prediction of these systems. We may have a number or get a number as an output, and we may have some knowledge about the general performance of the systems because it has been tested in trials. It has been tested it has undergone scrutiny by experts. But we don't know in most cases, we don't know what influenced the decision of prediction, of a prediction system, of such a system in an individual case. And what makes it even harder is that sometimes we have fundamental tension between accuracy and transparency. Because the most complex and opaque systems are most often the most powerful and the most accurate ones. They perform very well because they take into account a large number of data and variables. And it is that specific characteristics characteristic that makes them also too complex for a human mind to understand. That's why we sometimes have a tension between accuracy and transparency. While the black box problem is widely known, there are different forms of opacity that are discussed in the literature, and I'm only going to mention just 3 forms of opacity, namely technical, epistemic, and social or institutional opacity. I will begin and briefly comment on the last one. So social or institutional opacity is the opacity that was discussed in scenario B in my first lecture. So there are systems for which the algorithms used or the training data used in their training are not disclosed to the public, but they are proprietary to the company. The company is not open about them, makes them not available to the public. For example, if you use sleep trackers that are integrated into your fitness watch or other forms of commercially available tracking devices that give you then a score, at the end of the day, you normally cannot access the algorithms and underlying these systems. They are opaque to you as well as to your doctor. And they are not opaque because because they are too complex for experts to understand, but because the company doesn't want you to know how their system works. So this is what most often happens with proprietary commercial systems. The other 2 forms of opacity are different. In the case of technical opacity, this is an intrinsic property of the model. So the model in itself is mathematically very complex. There are hundreds of millions of parameters interacting across many layers, and even if you had full access to the system, the process would still be too complex to understand. That's technical opacity. So the deep learning systems. Epistemic opacity is still different. It is not a property of the model, the system itself, but of our knowledge about the model. We may not exactly know what training data was used and what biases those training data contained. This is a type of opacity that is in principle reducible. So better records and more research could help to close that gap. A useful test to distinguish between both forms of opacity is the question, would full access and perfect documentation solve the problem? If yes, then it is epistemic opacity. If no, then it is technical opacity. But of course, the line between the 2 may be blurred in practice. Why does this matter ethically when we want to keep the patient in the loop? That is, if you want to ensure that the system realizes patient-centered care and the ideal of 4P medicine. The black box problem, in whatever form we have to deal with it, limits informed consent. That's the first problem. So patients cannot meaningfully consent to a treatment recommendation if they or their doctors cannot fully understand how the recommendation was made. So this is a problem for patient autonomy. But it also limits the doctor's ability to fulfill their duties of beneficence and non-maleficence. So if a doctor does not understand the basis of a recommendation, they are in a state of professional uncertainty that limits their capacity to make the best choice for the patient. And it also limits our ability to detect discrimination and to assess the fairness of AI-based systems. If we cannot see how the system works, we cannot check whether it treats some patient groups unfairly or not. So this is a problem for justice as an important moral principle in healthcare. The Second challenge that is often discussed in relation to decision support systems is the automation bias. Automation bias refers to the tendency of humans to over-rely on automated systems. People follow the system's output even when it is wrong and even when they have, in principle, enough knowledge to recognize the error, to recognize that the system must be wrong. A very common and famous example can be found all over the internet, and that is the example of drivers that blindly follow their navigation system, although their common sense should tell them this cannot be right. What that example shows is that the automation bias is not specific to artificial intelligence, but it is related to all automated systems. But AI seems to make the problem worse than the older automated tools did for several reasons. First, AI systems often produce confident, fluent explanations. So a large language model, for example, does not just give you a number, it gives you a paragraph of reasoning. This gives the output an appearance of higher authority, and you think you can trust it, and you follow it, and you fall prone to the automation bias. And second, and paradoxically, explainable AI tools, so explainability techniques, which are designed to make AI more transparent, can actually increase automation bias. So when AI highlights a region of a scan and says, this is why I flagged it, the explanation the AI gives feels like verification. And it may reduce the clinician's inclination to critically re-examine the output and makes him or her fall prone to the automation bias. And a third reason is that the environments where AI decision support systems are most useful, and these are environments like high stakes, time pressure clinical situations, for example, surgery. So these are the situations where they are most useful to support clinicians. These are also the environments where people are most likely to offload their thinking to a machine and fall prone to the automation bias. This is both understandable, but it is also dangerous. So this is where the automation bias is most prevalent. The third challenge that I want to comment on is the responsibility gap. When automation bias leads to harm, so when something goes wrong, then the question arises, who is responsible? Is it the clinician who relied on the system and could perhaps have known it better, or maybe also not? The developer who built the system, but who in no way could anticipate every possible situation in which his system is later used. The hospital, which purchased and deployed the system, but may not have fully understood how it worked, or the AI system itself. Well, for the last one, we would probably say no. An AI system cannot be a moral or legal subject. It has no intentions, no interest, at least at the moment, and no capacity for guilt or reform. Therefore, it cannot be the responsible agent here. So what this shows is what philosophers call the many hands problem. Responsibility is distributed across many actors, and as a result, responsibility can become diffuse. If everybody is responsible, nobody feels fully responsible, and this is a general problem. The responsibility gap is often discussed and referred to as a structural barrier to the wider implementation of AI-based systems into clinical practice, especially those AI-based clinical decision support systems and the diagnostic support systems that I briefly depicted at the beginning of the second part of my lecture. However, I want to stress that although this problem is mainly discussed at the moment in relation to AI-based systems in medicine, this problem is not entirely new to medicine. Medicine already deals with distributed responsibility all the time, in multidisciplinary teams, in handovers, in complex chains between a decision and its consequences. And clinicians and institutions in the healthcare systems have developed practical ways to deal with this without waiting for philosophers to resolve the many hands problems. So AI introduces a new version of an old problem and not an entirely new one. What follows from this is that legal and insurance frameworks will need to adapt, and first steps are being made at the moment, for example, in form of the European AI Act, which may help to resolve that problem. The fourth and last challenge that I will mention concerns privacy and data. Machine learning systems, especially deep learning systems, need large, diverse, and richly labeled data sets to work well. So this creates a structural pressure to aggregate patient data at scale, across institutions, across time, and also across national borders. And at the same time, personal health data is considered amongst the most sensitive categories of private information, both legally and ethically. And the traditional model of informed consent, which is very common in the healthcare system, where a patient is explained at one specific moment in time exactly what will happen with their data, by whom and for what purpose, this fits very poorly with the realities of AI development, because the data we collect today, we don't know what we are going to use them in 1 year, 2 years, or 3 years. So hence, it's not something that we can explain to the patient. Data is often reused for purposes that we cannot anticipate at the moment, or we cannot anticipate at the moment it was originally collected. Furthermore, what one also has to take into account is that with the more AI technologies available, there's also a growing technical risk. As more data is combined and technologies improve, there is a growing risk of re-identification of anonymized data. And this is not just a theoretical risk, but is also something that has already been proven as a realistic risk in studies like the one I have put you here on my slide on the bottom right. And this brings us to an interesting shift in how researchers, legal scholars, and ethicists are thinking about data governance in the healthcare sector. So the traditional data governance models focuses on protecting the individual, giving each person control over their own data. But some argue, and I have given you already some examples and reasons for this, this individualistic model is not sufficient for the realities of digital healthcare and to make the most out of our digital tools and especially AI in healthcare. And that's why an alternative has been presented, that is the concept of data solidarity. So the idea here is to shift from individual to collective governance of health data by strengthening collective control and collective ownership of our health data, our healthcare data, the data that has been collected during our treatments. And the focus of that governance should be on to ensure that both the benefits and the burdens of digital practices and the use of our health data and the health data of us as a society should also be shared fairly across society. This connects the issue of the use of health data for AI to the broader tradition of public health and public health ethics. So public health and public health ethics concerns itself with the dealing of infectious diseases on the population level, the question of mandatory vaccination, for example, and so on and so on. in public health and in public health ethics, not the individual is in the focus, but the well-being and prosperity of society as a whole. And that solidarity asks us to look out for each other in our society, and also to especially look out for the most vulnerable persons and groups in our society, and that we each should give a fair share, in that case our data, to improve the situation for the vulnerable, but also for everybody and for society as a whole. Let me now briefly summarize. Digital transformation of healthcare should be understood as an aspiration, the aspiration to promote patient-centered care, to keep the patient in the loop. But what does that actually mean? In the loop, a patient who is in the loop in a meaningful sense, he must be, in order for him to be in the loop in any meaningful sense, he or she must be able to understand how the tools being used work and what their limitations are. This is the challenge of the black box. The patient must be able to trust that the clinical recommendation he or she receives reflects genuine professional judgment and not just mechanical compliance with an algorithm. That is the challenge of automation bias. The patient must be able to ask who is responsible when something goes wrong and receive a meaningful answer. This is the challenge of the responsibility gap. And he must be able to make informed choice about how their data is used, but should also be held responsible as a member of a community, not just as an isolated individual. And this is the tension between privacy and data solidarity. So these four challenges are not reasons to reject AI in healthcare, but they are reasons to develop and deploy it carefully with the patient always at the center.